about calcium stuff? No, because it doesn't start with LFTs, cholecystitis. Tomorrow, but anyway, if you do run into questions over the weekend, you text me, or on Monday, I will be here, because my boss will now be here. My big Air Force boss will be here on Monday for that joint thing. So, but I will leave to go over questions if you have them. So, what else? Oh, so I now have a 13-year-old. He's officially 13, and he didn't want to do anything for his birthday, which sucks because we're big on birthdays because they're military kids and we move a lot. But I feel old because of that. And then I had to share with you guys. So did anybody shop at PacSun or that when they were little? Yeah, okay. And I worked at American Eagle when I was younger. So I took my son school clothes shopping, and usually he just wants Nike, which is kind of annoying because it's just the brand name. Last year he just wanted Nike, and this year he's like, "Can we go to PacSun?" And I go, and guess what? All of the clothes are like the clothes I wore. So like I have a 13-year-old now, so I'm old, and now the fashion from when I was younger is that, but like the men's, like they still have affliction shirts, like that's still a thing. So anyway, anyway, so I was just thinking about that this morning with my husband. So anyway, all right. So speaking of age and getting old, we're going to talk about osteopenia and osteoporosis, and that was not intentional. But okay, so done specifically with the hypocalcemia and the hypercalcemia. But remember, hypo and hyper present very differently. When we're dealing with hypercalcemia, you're going to check PTH, right? And that can point you to the direction. With hypo, it's a little funky because we have that pseudo-hypoparathyroidism where it's not really low PTH, right? The problem is that the kidneys aren't responding to the elevated PTH, and then the nice and easy hypoparathyroidism with hypocalcemia, okay? All right, we'll talk about that a little bit in a minute. So after we finish this up, we have some check on learning and clinical cases, and then a quick review, and then that's it. All right, so osteoporosis, you guys talked about this in ortho maybe a little bit. What's the problem? What's the problem with the bones? It's density, right? So loss of bone density. So who gets this? Yeah, elderly, specifically Caucasian women in like the smaller frame. Do men get this very often? Yeah, so it's rarely, I've rarely put an order in for a DEXA scan for a male ever, but there are risk factors of why you may screen for a male or a younger female. So we'll go over all of that. This is absolutely pants stuff. This is stuff you'll see, especially in the Air Force. When I was in Ramstein, I did not do a lot of osteoporosis and osteopenia. And the first week back when I went back to Colorado, and every week we as providers we would meet and we would talk about a medical topic, and the first topic was osteoporosis, and I was like, oh no, I don't remember anything, but it comes back really fast. So if that happens to you where you're doing a lot of like healthy young individuals and then you switch clinics and go to a more seasoned population, it'll come back to you. All right, so again, loss of bone density. Here's the kind of breakdown of it. With loss of bone density, we have increased risk of bone fracture, and that is really concerning for our elderly, specifically hip fractures, right? There's a high mortality and just like impact on quality of life when people get hip fractures. 20% of patients over 50 potentially have one or more fractured vertebrae. Just interesting. Not on the test, but just interesting. And then again, this talks about Caucasian women that are more at risk for these osteopenic fractures. Especially those, because why does estrogen replacement play a role? So as they age, what does estrogen do? It's like testosterone, what does it do? Shuts down. And so that those protective qualities of estrogen are gone. And then, so if you take HRT, if you're able to, risk benefit, you're able to take it, it can delay that osteoporosis risk. All right, so vertebral fractures are the most common fracture, but a lot of times they're incidentally found on like an x-ray. But hip fractures, I've already said this, high mortality risk, lots of pain, reduced quality of life, that goes with the reduced independence. For sure, this is always really sad if you don't probably do, no, you don't do any like elderly care rotations or anything, but hospice, those kind of patients, or any kind of assisted living, they deal with this quite a bit, and it's a bummer. I met family members who have had hip fractures, and yeah, it's a big bummer. Okay, so this is for current. So you see there's lots of causes of, potential causes of osteoporosis. I highlighted the ones we're going to talk about. So this list, like at the meds, there's only 2 meds. Corticosteroids are coming back to haunt again. And then hormone deficiency makes sense for endo, right? Low estrogen, low testosterone for men. We have female sex, and Caucasian. Oh, soda, is this cola? I don't know what type of soda. This was new, I learned this last semester. I was like, I wonder why. Smoking for sure is an increased risk factor, and alcohol use of alcoholics are at increased risk. And obviously age, which we already know. Okay, so here's your DEXA scan. This is probably what ortho introduced, maybe radiology. Just understand this is what you order. I do not go into the details of how this thing works. But again, it's how we gauge bone density and then essentially their risk of a fracture. Okay. So here's again kind of the breakdown of it. And if that box in the middle is if you are a radiology guru or nerd, there you go. But what I care about as a clinician and PA and what you guys care about is the T-score and Z-score. Okay, so T-score is used to compare with a healthy adult, and then Z-score is the patient's peers. Okay, so kind of narrows it down. And we'll go over the ranges in just a minute. Okay. The U.S. Preventative Service Task Force, USPSTF, they recommend screening at age 65. You will see, at least when I was in clinic, you will see people specifically in your women's health clinics, nurse practitioners, or maybe usually it was in the military, usually nurse practitioners, that order DEXA scans on 50-year-old women all the time that aren't high risk. You're not supposed to do that. The guideline, the purpose is to wait unless they're high risk, like if they're not a smoker, they are an exerciser, they apparently don't drink a lot of cola, I don't know. If they're low risk, you wait till 65. And the reason is because if you do it earlier and you see some osteopenia, and then maybe you start treating earlier, it's not right, it's not best for the patient. So you want to wait and save the meds and the treatment for when they need it. By all means, you can recommend calcium and vitamin D for women in their 50s, especially Caucasian women. But we don't start DEXA scans till what age? 65, unless they have increased risk, so smoking, alcoholism, corticosteroids, that sort of thing. Okay. And again, males, not so much, right? We're rarely screening that. So here's our ranges. So it's the minus 2.5. So you can, whenever there's like a negative number, it can kind of get a little bit confusing. But again, like normal threshold is 0, and there's a bone density loss, so that's why it goes into the negatives in my brain. But yeah, negative 0.25 is osteoporosis. That's an important one to know. We'll talk about what osteopenia is, like that pre-osteoporosis phase 2, and then severe. Okay. Is that's not new, yeah? Or is that new? Is that ortho? Okay, good. So speed up. All right. So this is probably new. So fracture risk assessment tool, or the FRAC. So this is something that I saved to my favorites on my computer when I was PA. especially dealing with older population. And it's going to assess the fracture risk, because that's the whole point, right? We want to prevent fractures for these people and falls, and do our best to improve their bone density. So this, you put some information and demographics into the system, and it gives you your 10-year fracture probability based on gender. So just like ASCVD risk for heart disease and things like that, it does that. And it can just help determine, do we need to start this person on medication? So it's like another tool, right? Ideally, we want to individualize medication if we can to the patient, but it's another tool besides just that DEXA score, okay? Is this new? Maybe, yeah. This one is really helpful. Remember that when you're in clinic. Okay, so this is FYI labs, where you can order labs. It's not required because we have the lovely DEXA scan. But again, you could, I think the testosterone makes sense in males, like if they're really low, and for whatever reason they can't be on hormone replacement therapy for their low T. Yeah, but FYI. Okay, yeah, no labs. All right, osteopenia. So this is that kind of like pre-osteoporosis range, -1 to -2.4. You got your table there again. And these people typically don't require prescription medication. Absolutely, you're going to do calcium and vitamin D all day for these women. And then if you do the FRAX score in addition to the T-score, this will help you determine like, ooh, even though your T-score is say like -2.1, your FRAX score puts you at a higher risk for a fracture. So maybe I'm gonna start you on treatment. So again, it's how you can use more than just one guideline to help you determine treatment for your patient. The specifics of like where it says the FRAX determination, you don't have to memorize that, but just know like, oh, okay, I have this other thing that can help me determine if I need to treat this person. And then not again, look, oh, it's prednisone. Prednisone, what does it do if I'm on long-term corticosteroids? What happens? Cushing's, what else? What happens to my bones? Osteoporosis, right? So in that way back in lesson something, anyway, five or maybe 3, and there's a picture of excess. We need cortisol, right? Cortisol is good, but when we have excess steroids, we could get the central obesity and then osteoporosis. So it's coming back to haunt you. I think it was a possible test question too. Or good. All right, so and I know you learned it in farm. Okay, osteoporosis, there's your definition, we already got that. Severe osteoporosis is either a T-score below 2.5 with a fracture or 3.5. Again, just 2.5 is fine for you to know, but know that there's ranges. Okay, straight on to treatment. Because again, no labs, just a DEXA scan, and we know about the FRAX score now. All right, so calcium and vitamin D supplementation for everybody. Again, as women enter menopause in their 50s and stuff, you should have that. Ideally, you get it from food and all those yummy cheeses if you like them. If you can't handle that, a supplement. Vitamin D, usually, again, I'm like 1,000 to 2,000 units daily. You can have up to 5,000. None of that's on the test, it's just clinical. Is vitamin D in a multivitamin, do you think? Is there enough vitamin D in a multivitamin?
No.
Yeah, it's not. Same with calcium too. Sometimes they'll have those vitamins that are like for females and they might have more calcium, but typically you have to do another supplement. And again, I mentioned calcium by itself can upset the stomach. So there's like concoctions where you can add like magnesium and other things to help. Okay. Typically, I think TRICARE, I know I used to prescribe vitamin D and then pharmacy would cover it, but doesn't do that anymore. Definitely didn't do that on the civilian side, but I think calcium you can put it into Genesis and I think it'll be paid for. I do remember doing that. So stop smoking, absolutely. This is a significant risk factor for osteoporosis, so they should stop smoking. For all the reasons, but obviously to help prevent fracture, decrease their alcoholism, should be no surprise, and then exercise. So they need to do weight-bearing exercise. So love swimming, that's great, but you need to do weight-bearing exercise. So nowadays, the women are wearing those weighted vests. That's like a new thing, but it's actually pretty smart because again, it's that Yeah, or just lift weights. That's awesome too. But walking is helpful and considered resistance exercise. But again, look, walking helps the spine and hip, and then that resistance exercise helps the spine. And I added that in just to kind of like hit home how awesome exercise can be for these patients. And then fall prevention. What do I mean by that? Remember thinking over 65, what do these patients, yeah, they trip. So what's like a thing that you could tell someone for fall prevention? They could do at home.
Safety bars.
Safety, like what up? Like, yeah, like a shower, like the mat in the shower, or when we moved into our house in Florida, the guy, he was a lawyer, he had so many bars on all in the shower in the master bath. I was like, oh my gosh, this guy can never fall. But anyway, yeah, you can do bars, they're gone. Bars in the shower. Also, rugs can be kind of tricky. So if it's like a loose rug, you could fall. Using the sidewalk, don't walk through rocks and stuff, they could fall. Caution with pets, because they can take you out, but yeah, little things like that. So if you're at risk, the cool thing that you may or may not see, in phase 2, I would have home health come and talk to the students, but it's covered by insurance, but you can put in a referral for home health, and somebody, usually a nurse or a tech, OT, PT, whatever it is, they come into their house and they help them with fall prevention. Super cool. And she would come and she would have us sit on our stand on, it wasn't one of those balance boards, but a pad, and she would have you close your eyes and you would just see how balance is tricky just for these people, let alone walking and tripping. So our insurance covers home health. They can also help with medications and other things, but they will help with safety for these patients. So utilize our resources. All right, so here's the medication options, so calcium and supplementation, and then some prescriptions. And I'll let you know what you need to know about. So here's the dosing if you need it for life, but just know what? Calcium and vitamin D, all patients, right? And not just a multivitamin. And then anyone who's on prednisone, so maybe you have that asthma patient that just really needs to be on it, or that room patient, they should also be taking calcium and vitamin D. Did you guys remember learning about the Depo shot? I forget the generic name, sorry. Those people also should be on calcium and vitamin D. Do they still recommend a drug holiday for that? They did for the longest time. They couldn't be on Depo for more than 3 to 5 years because of the calcium stuff. So again, just other patients that need calcium. Okay, so bisphosphonates. You guys familiar with this word? Do you remember this one? So this is your first line medication for people with osteoporosis, okay? And there's different options, whether that if you have somebody who wants the pill versus an injection. Obviously insurance cost makes a difference on what they'll pay for, but they all kind of work the same. They inhibit osteoclast, induced bone reabsorption, right? And the goal is they can increase bone density significantly, and then therefore reduce what? Fractures, right? So we're strengthening the bone, reducing fractures, and preventing that loss of quality of life, okay? There's some that are better for vertebral fractures versus hip fractures, but I don't go into that. But again, first line class, that's what I need you to know, okay? And then just all the generic names all kind of end the same too, which is helpful, but first line. Do these patients, I'm starting somebody on bisphosphonates, do they also need to be on calcium and vitamin D? Yes, we recommend it. Okay. The drug holiday, that won't be on the test, but that's a real thing, and that just means that they just can't be on it for more than 3 to 5 years. They need to take a break for those. Okay. Bisphosphonate side effects. A lot of times, because remember, if this is a small little lady and she takes these, and it can give GERD and nausea and be significant. So when they take it, have them be upright. Don't just take the pill and then go take a nap. You want them upright, and that can help with the GI side effects. And then obviously, don't use it if someone has Barrett's. Definitely, it's a no-go for that. And then obviously, there's some things if you do the IV option. Do you guys remember learning about the receptor activator, nuclear factor, kappa, beta ligand? Yeah. Denosmap is the generic name for Prolia. Prolia is now considered a first-line option, and insurance does cover it. This isn't, it's 6 months, right? I think I'm going off memory. It's six months, and it's an injection. There's no drug holiday with this. It inhibits the protein involved in bone breakdown, so it'll inhibit proliferation and all of that stuff. Yeah, so this is another option for first line too. That TRICARE will cover, but a lot of times people just want to go. Usually they'll go with the bisphosphonates first, which you can consider this monoclonal antibody. This one you're like on for years. Like I don't think there's not like a stop date. But if you have somebody who can't handle bisphosphonates, you could go to this too. Parathyroid hormone receptor agonists. They stimulate the production of new collagen and bone matrix, particularly in the vertebrae, and help with mineralization there. So if you have like someone who has like multiple vertebrae fractures, this would be a good option. It's only 2 years, and then after that, they start bisphosphonates. Okay. Let's just do FYI on this one. Okay. All right. And then hormone replacement therapy, absolutely, like for especially maybe if they have like osteopenia or high risk for various reasons, you could do hormone replacement therapy for women. That comes with risk, so you have to weigh risk benefits on that. And then obviously males, it's testosterone. But does that treat osteoporosis? No, right? It's prevention, right? So again, that's not a treatment option if I have someone with osteoporosis. And then SERMs is also prevention, not treatment. These other options in here, these different, like another monoclonal antibody, things like that. It's just not needed for this level, okay? All right, that's it. Any questions on osteoporosis, the meds, anything like that? All right, ready to participate. All right, so we have a 51-year-old male with hypertension, type 2 diabetes. It presents for a 3-month follow-up. He has been taking metformin, 2,000 milligrams a day, doesn't always take his medication. Oh, I remember this one now, sorry, it's coming. Medications as prescribed due to the side effects, specifically GI, but mostly he just forgets, right? This is a Florida patient, for sure. No. Okay, so let's look at these labs. So this is like a picture from Ulta. So what do you notice?
Calcium's high.
Calcium's high, 10.8. The top, we know he's a diabetic. Would you say he's controlled?
No.
No, right. How old is he again? Sorry, I already forgot. Yeah, how old? He's 51. What's our goal A1C for this guy? 6.5, right? So he is high. All right, good. So we have this. We know all about this type 2 diabetes. There's been a whole lab on it, so don't worry, we're not going to do it today. Because you guys already know this. But we adjust his meds to reach his goal. You guys got that, 6.5. What do we do about this calcium? It's just a little high, right? 10.2 versus 10.8. What should we do anything about this? Yeah, we need to check PTH. Maybe repeat the calcium one more time and check the PTH. Perfect. Okay. What can cause elevated calcium? Ugh. I know, so lucky though. What causes? So, what hormone increases calcium, or what hormone increases calcium? PTH. So, think of those issues. What are those things you talked about? Yeah, that one can't cause high PTH but low calcium. What else? What about you have 4 parathyroid glands? Something. What is it? Adenoma, yeah, that's the most common, parathyroid adenoma, parathyroid hyperplasia, cancer, super rare, but can cause all sorts of mess. So you have parathyroid cancer, can cause increased PTH, and therefore cause increased calcium. But cancer in general can cause super high calcium or borderline calcium, high calcium, severe, right? So this one isn't a red flag for malignancy, but that's another cause for it too. Okay, here's all your stuff. Yeah, and meds, right? Meds can cause this too. Okay, so what do you want to do next? You already know we're in endo. All we have right now is 1 calcium. What do we want to do? Yeah. Oh, this time I tricked you. Sorry, I haven't looked at this for a minute. Before we order those labs, why are we asking about these? Right? The stones, bones, groans, moans, overtones. We need to ask those symptoms. I was talking to one of you guys yesterday that people who have, especially parathyroid adenomas, their symptoms are really mild and they are kind of used to maybe constipation, or they think maybe their myalgias are because they work out, right? These aren't like unhealthy people. It could happen to anybody. So they might be true that they are really mild or asymptomatic, but if they have kidney stones, recurrent kidney stones and the other things, you'd be suspicious. Okay, so now we're gonna do labs. You guys already got this, so calcium, we repeated it, and it's 11.2, still high. PTH, 72.3, that is high. Vitamin D, we always check that when calcium's off, and usually it's always low, but for the sake of this class, we're gonna say it's right at the edge at 29. So, what should we do? So we have high calcium, high PTH. What do we do? Would we treat this with like a mind? Did we send them somewhere?
Check the kidneys.
Ultrasound maybe. Yeah, ultrasound. Endo is the ones who's gonna, if we deal with treatment, they're gonna send that. But yeah, you can do an ultrasound. Ultrasound's not required for treatment, but you definitely can. So again, we're sending them to endo. Ultrasounds will catch 79, so roughly 80%. And if the ultrasound doesn't show something, what can you do while they're waiting for endo? Do a CT. So in July, we refer to endo. This guy gets a DEXA scan. Maybe he was a smoker, and then again, or maybe he had, and then they're concerned because of the calcium. They do a neck ultrasound. Bone density scan is normal. Ultrasound is unremarkable. Okay, so here's our picture. So from July, we put the referral, August, we get the scan back. Then he goes to endo, they repeat the labs, and they're still high. They add the urinary calcium, which we could have done, but it's not required, and it is high. And then they do a CT scan, and there's something on the right side of the thyroid. They did a PET scan too. What do you think this is? Yeah, the adenoma, right? It's the most common cause, and yeah. So based on the levels, this person's 51. They're not great at just taking their diabetes meds, so they are because they have diabetes, they're going to come in every 3 months. Because remember, for our asymptomatic patients with this, you can just observe, but you have to do lots of labs. But they recommended parathyroid adenoma removal. He had the surgery, and he felt better. This is what I always thought, was like, hey, I actually felt a lot better. I didn't realize that I didn't feel great before this. Feel okay with that? Okay. All right, so we're not done. That was just for yesterday. I think we were finished. Okay. Not as scary. I think the hypercalcium stuff isn't as scary as the hypo, or confusing. Okay, good on time. I did add these, but not till this morning because of the birthday stuff last night. So this is on there, but you don't have to have slides for this because it's mainly just a review. But before I talk, dang it, I apologize. I thought I had the check on learning. Let me see. If I don't have check on learning, I will do that tomorrow. I don't have internet, so I can't. Yeah, we'll do it tomorrow, just because I think it's worth it to practice a few of those calcium ones. So I guess I'm stuck up here. We'll just do a review. Okay. Good. Okay. What was our first lecture way back when was obesity, right? So it should be no surprise that we've been quizzing you throughout this whole time, and obesity keeps coming up over and over again, so it's kind of cool it's in endo instead of GI, but you need to know the different classifications of obesity. We use BMI. BMI is not perfect, right? Because just because your BMI is high doesn't mean you're obese. You could just have a lot of muscle, you could be really tall. Specifically unfair for you guys, sorry. a lot of times your per BMI will be obese, but you're really not, right? So you still gotta look at the patient. But we use BMI. So what are the classifications for overweight? 25, yep. Oh, it's class 1. 30, class 2, 35, class 3, 40. Awesome, so know that, and then you need to know from the BMI, when can I start a medication? When can I send them for bariatric surgery, okay? You have to know those because TRICARE won't cover that if you don't follow these guidelines. So understand those two, should be no surprise because we've talked about them a lot. Again, the interventions are really straightforward. Lifestyle modifications over and over again, exercise, we have referrals, we have dietary stuff, mental health, various things. Super, super important, but for whatever reason it's really hard, so then we also have medications. Know the medications. For obesity, the review, luckily you've had them before, but it's a good idea to know when to use them. When not to use them is important, right? Because phentermine is really specific, right? It's a controlled medicine versus a GLP-1. You guys know about that. We talked because of diabetes, so that one you already probably know really well. But again, know those. The surgeries, we talked about 3. I'm not going to go into details on that. That could be maybe next semester if they want to talk about it, but when to refer and just like to educate the patient about that is important. Yeah. And any questions about this? Secondary effects on obesity. What are the like comorbidities associated with obesity? There's a lot, right? And we talked about a lot of them. Diabetes, hypertension, hyperlipidemia, you guys already know, all the things about that. But metabolic syndrome, prediabetes, diabetes, right? We've talked about this. PCOS, obesity snuck into that lecture as well. Also, it's stuck into the gynecomastia one, right, as a risk. So obesity is trickled all throughout this as well. Pretty straightforward topic. Oh, and then I'm sorry, I didn't know I had more. Oh, cool. I forgot to put that in there. I already said it. Awesome. So we talked about that. And then Cushing's is more last lecture, but it's in there too. Same with the thyroid. Questions on obesity? Feel good? Okay. Diabetes. So this was the biggest section, so probably going to have the most amount of questions on this guy. But you've learned a lot already. Pathophys, you know the difference, pathophysiologically, how type 1 and type 2 are different. Know the signs and symptoms. What's the signs and symptoms of someone with type 1? Polyphagia, they're hungry, but then they're losing weight, right? Is this an old patient or a young patient? You know that, right? Yeah, it's young, typically. But know that, and then obviously young people can get type 2 too. How do you diagnose it? Know the ranges. I'm going to show you those in just a minute. Management guidelines, that's kind of like going in like with the lifestyle stuff, the nurse educator, understanding the goals for, if we're going to treat someone for diabetes, we need them to understand the goals as well. And then we'll talk about meds in a minute in great detail. Okay, so this is a slide. At the bottom, it tells you the diagnostic for diabetes. Majority of the time, I tell you the ranges, but I do not for diabetes because you guys need to know these. So, know that. Okay, back to review. The meds, there were 7 meds. These, you guys taught these, you guys know these. Understand, obviously I'll use the generic names. Sometimes I'm guilty of not doing that, but I'm trying to get better. Mechanism of action, right? GLP, not too specific on the mechanism of action in this class, but understanding maybe from the mechanism of action, what are the advantages of it and what are the adverse reactions and contraindications for the patient, all right? Because we know we use SGLT2s for certain patients, but they have certain side effects. Same with GLP-1s. Metformin absolutely has certain side effects, right, that we need to educate our patients on as that first line type 2 diabetic medicine. The weight impacts in hypoglycemia, right? That's a huge, huge, huge deal. So which medicine causes hypoglycemia? You should know that. Insulin, obviously, there's an oral medicine too, right? Thankfully nowadays, when I was in school, there was a lot that caused hypoglycemia, but nowadays we don't have that. It's a huge, huge one. And then when do we start insulin? Be comfortable with that, right? If they're maxed out on 3 meds, if their A1C is crazy high, over 10, and not controlled. Okay. We don't like to give insulin, remember though, because we have other meds, but it's there if we need it. For our type 2. What do we treat type 1s with? The only thing we treat them with, right? Insulin, insulin, insulin. No, we had 4 different types. I told you they're like the same graphics that they had when I was in PA school. There's pearls on a few of those, so know those. When do we use them? And then being able to educate about hypoglycemia. And of course, the dance emoji. Right, so with that, anybody remember? So they have high glucose in the morning, and you have to check it, have them check their blood glucose at 2 in the morning to see if it's high or low, and then from that, you determine if you need to increase or decrease the nighttime insulin. So just review that, so you understand. This is just, like a GWIS, just remember there's tools of like every 3 months, gradually increasing the meds. It's like to hit home, understanding the meds and why you're going to treat them, and then insulin too. Okay. This is just that transition of like, why am I so aggressive with these meds, or why can I not ignore these this gradually increasing A1C? Is because of the relationship to complications. All right, so complications. That was the, I guess, part 2. We talked about hypoglycemia. Understand, why do you need to know how hypoglycemia presents? Why do you need to know that? Like, you should never forget that. Right? Because you have to tell your patients, right? You need to educate them. So then you have to educate them, their family members, so they can be aware, right? That hangry, initially they're hangry, and then it drops lower, and the brain gets involved, and there's some additional, instead of the parasympathetic and sympathetic response, there's some neurogenic stuff mixed in well. DKA versus HHS, or HSS. Don't fix that. So DKA is that type 1 diabetic they either present with type 1 diabetes and DKA, or they get DKA during the span of having type 1 diabetes. So understanding the difference of those, right? So you would look at the blood, or excuse me, the A1C, the blood glucose really is a huge driver. How they present very differently, right? One's in acidosis and one is not. One is a lot older, maybe has some CHF and other things that led to it, and was more gradual. But understanding those. Okay. With that, understand what do you treat these people with? If DKA and I have diabetic ketoacidosis, right? I'm a type 1 diabetic, my body does not make insulin. What do you treat them with? And I have polyuria, polydipsia, I am hypotensive, I'm tachycardic, I am vomiting, I'm nauseous. What do you do? Fluids, yes, get that line in. Throw on that insulin. Ooh, but we need to make sure we have what additional lactic acid, right? Yeah, that's it. And actually, I had this like that, just as a reminder. Sick day guidelines, so that's, I'm doing it again. That's for the, more for the type 1 or anybody who's on insulin, right? If if they're sick, what they need to do. Or again, I correlate that also with like family members, right? So what's that kit that every diabetic should have in case of an emergency? Yeah, glucagon, right? For adrenal insufficiency, it was like give cortisol or die. This one would be like give sugar. And know what type of sugars and what you can do when someone's hypoglycemic. Okay. Complications, this was the rest of that part 2. The macro and micro, the ocular, right? Diabetic retinopathy, nephropathy, knowing the labs and screening for that. Neuropathy, there were a few types, right? So that bilateral distal symmetrical neuropathy, that's neuro. You guys had that. That one's the most common. But then there's the isolated peripheral neuropathy. What else? Oh, the autonomic, right? So the gastroparesis, the erectile dysfunction, just like being able to understand those. What's their cardiovascular issue with these diabetics? What do we need to think of? Any diabetic type 2 who has diabetes in their heart? Hypertension, yes, what else? Got like PAD, peripheral arterial disease, right? Stuff like that. We practice hyperlipidemia. What meds, know the meds for those, because they're important, specifically if you have a patient with diabetes. Oh, ED obviously overlaps with that too. Diabetic foot for sure, we talked about that. That blends the neuropathy plus the cardiovascular stuff, and it's no bueno, right? And then there were all those skin findings. This isn't derm, so I'm not gonna be like, here's a picture of this. What is it? But if I decide to use a picture, it will just be part of the story to help you if I decide to use it. But still, you should know those. But does that make sense? We're not in derm, and I want you to know more endo-y stuff than here's a picture. What am I? Okay. Guidelines, know those guidelines. Guidelines are really important for when to refer for opto, what labs I need to do for various things, and yeah, because diabetes takes a team. All right, so here's that DKA. Any questions on diabetes? You guys will be fine. There's a lot on diabetes. There just is, because it's a lot of this course. Obviously, obesity, maybe 10%, but diabetes, I don't know the percentage, but it's the most, okay? All right, hypogonadism, only one pathway with the anterior pituitary. Understand what normal is, right? You guys got this, we reviewed it, I guess 3 times, because it came up in 3 different lectures. But again, it's the FSH, LH, pathway, how LH gets to testosterone, and then once we have that testosterone, what does it do, right? It goes and does its work in all the target organs. It impacts DHT, so we get that viralization, those male pattern, the voice changing, all of that stuff. And then if it's an excess, maybe it can get aromatized, or if it's not necessarily an excess, it can also like if it's obesity and things that can get aromatized as well. What is aromatized testosterone equal? Excess what? And then what does that present clinically? Gynecomastia potentially, right? Okay. Here's this lovely thing. I took the slide with like the hypogonadotrophic and hypergonadotrophic, hypogonadism, right? So this is all hypogonadism. And just, you should know these. And then they added the little table, so you have the reference. So if you're like study, and then you go back to the slide, you're like, oh, okay, I got it. XXY, I understand that. Oh crap, XY dysgenesis versus, what was the other one? Right, so the insensitivity syndrome, you can just kind of use this maybe to make sure you understand it. Questions on this? The treatment for low T is all the same, right? It's testosterone, understanding the pearls. I really only talked about 2 main ones. But I did talk about risks and contraindications and things like that quite a bit if I give somebody testosterone. Sorry, I keep saying T. It's hard to have to break. Questions on this? Know the difference on Kalman versus Klinefelters. I think those can be confusing, but there's definitely differences. Okay. Oh, well, there you go. So complete androgen insensitivity, that is, and XY dysgenesis. How do those stand out? What kind of patient is showing up with a complaint? We're in hypogonadism, so we think male, but they are phenotypically female, right? So you have 2 like that, so that should already like narrow it down. And then you have to think XY dysgenesis. In the name, it's a dysgenic testes that are inside that aren't working because of some chromosome abnormality on Y, versus the insensitivity, it's insensitive to androgen. So that's why the labs are there. So the glands are working, pituitary is working, all of that, but it's insensitive and it happened in utero. So those ones are really fun, but I try to keep it mild. Okay, questions on Lati? Feel good? And then this one overlaps with gynecomastia, right? Understand the feedback loop if you need it. And then going back one, etiologies, right? There's the physiologic etiologies, there's the endocrine etiologies, there's the chronic etiologies, I intentionally spent more time on some of those etiologies than others, right? Medications can cause this, that sort of thing. Obviously, low T can cause this, but high T can cause this, right? When are we scared for cancer? What's scary about gynecomastia, right? Like the physical exam will tell us, right? Or if it's like a normal nodule, it doesn't seem like breast cancer, but maybe it happened sudden, or something about their history is just off. They're thin, it was rapid growth, they're sick. I don't know. What other causes of cancer am I looking for besides breast cancer? Yeah, good. And know all of the labs and stuff for that. Okay, got it. Hirsutism. I think I have this on animation. What are our 3 androgen labs? Our major one, our heavy hitter androgen. What is that? Testosterone. What are the other 2? Androgen. They either produce from the adrenals or the ovaries. DHEAS. What's the last one? Androstenedione. Yes. I can't speak French. That would be fun if I could. All right. So etiologies, understanding those, the familial and how that's unique. PCOS obviously most common, and then so on and so forth. Same thing. Labs. What am I concerned? Why am I concerned, right? So those labs or that clinical picture. Same as gynecomastia. That clinical picture can be scary. And then how to treat, specifically the hirsutism, not diving into fertility, even though it's fun. Questions on that? And then this last one, understanding homeostasis. So we have this to help you with homeostasis on what parathyroid hormone actually does, and then we have this to help you with the pathway, that homeostasis, when calcium's too high, when calcium's too low. So you can fall back on these. Obviously the organs that regulate serum calcium, obviously the bones, because 99% of calcium is stored in the bones, right? The kidney plays a role for reabsorbing calcium, and then it also activates vitamin D to reabsorb it in the stomach, okay? What hormones do I care about when calcium is high or low? PTH, and what's the other one I care about?
Calcitonin.
Calcium's already high or low. One more hormone that we could draw a lab for, that's why I care about it. Anytime calcium's off, what I check this. PTH, and it's a supplement that your patients all know this. Vitamin D, yeah. So if calcium's low, vitamin D is likely low, but it's not always. If calcium's high, vitamin D can be normal or low. So again, just know that's important. But does vitamin D always tell me where the problem is? No, PTH does, especially with hypercalcemia. Just don't forget about it. Go vitamin D. Your patients won't forget about it. They want you to screen it all the time. And again, pause for the test. Most of the time, people are low vitamin D and their calcium is totally fine. And just manage that as its own thing. Okay, I'm gonna wrap this up. We have like 4 minutes, and then I will leave you guys to it before 11. Okay, everyone okay with that? I guess we only have 2 minutes till the break, but we'll push.
Yeah.
Okay. All right. So hypercalcemia. How do they present? Stones, groans, moans. Right? How does a hypocalcemia person present? Neurologic. Right? The tingling, the numbness, the CATs. Right? Tetany, seizure, scary stuff. Right? We have our special tests. Right? The Torsades phenomenon, the TAP. Right? What is an emergency? Why can low calcium be an emergency? Yeah. We talk about seizure, arrhythmias, what a laryngospasm, right? Airway. I care about this. How do I treat someone in an emergency hypocalcemia, regardless of what's going on? Right, and then I transition to orals. Labs. We got this. Keep looking at the slides and then you'll get the labs, but the labs help you identify the etiology, and then again you can go back to homeostasis and understanding treatment. For osteoporosis, with the treatment, sometimes it's surgery, sometimes it's meds, right? So you know that. Osteoporosis we just went over, risk factors I talked about a lot, T-scores, and then how to treat it, right? Great, so this I kept and like adjusted. So hypercalcemia, and then it goes into the different labs. Do I care? I think it's cool, but do I care about FHH? That's when your parathyroid is normal and you have high serum calcium and high urine calcium. I don't. So you can put an arrow through that one. This one is what you're going to see the most of on the right, elevated PTH and high calcium. But the malignancy on the other side exists, okay? And remember, if the PTH is suppressed, that is telling me what? Is the parathyroid hormone working correctly? Because yes, it is, right? Because if calcium's high, parathyroid should take a step back and be suppressed. But even though it's doing that, there's still a problem with high calcium, okay? And then the shifting gears to hypocalcemia, the cats go numb. These are just like FYI, this is the most common, right? Alcoholism just messes up all the things, and then medications. I started out talking about the pseudoparathyroidism, right? So you think it's hypo because there's a receptor in the kidneys, and so it just can't keep up. The PTH is actually high, and it's hitting the bones a lot, and so it can be associated with Albright's hereditary osteodystrophy. So know what how these look clinically too, as well as with the labs, okay? And I don't care about vitamin resistance. And then suppressed. The easy one of this slide, just like I feel like this over here is easier. Understand that, okay? All right, that's all I got for the review. It's quick. We'll do the lab tomorrow later, not at 9, it's gonna be at 10. So come, I know you guys have GI, but get some rest, be ready to participate, and then we'll finish on time or early. And that's the walk around. That's how I get you to participate, is answer questions. Ask your friend. So, okay, all right. And then you can code up and you guys